This is today's topic, managing headache without tears. Headache is quite a common problem in general practice. Annually, headaches accounts for 4% of general practice consultations and 30% of referrals to a neurology clinic. And the burden caused by headaches, symptom burdens and the secondary burdens. During attacks, our patients suffer, leading to reduced functional ability, and between attacks, the fear of next attack, and they are worried whether they have something serious inside their head. Secondary burdens during attacks, lost work time, reduced effectiveness, and beyond the attacks, failure to meet potential cessation and even breakdown of relations. So, not only the physical consequences, there are the socioeconomic consequences attached to this headache disorders. I have summarized finding of a study entitled How UK GPs Diagnose Headaches. This is a retrospective cohort study. Data was gathered from primary care database. Some records of 91,000 consultations of patients with new onset headaches. There is no headaches in the past 1 year, and they followed up for at least 1 year from the index consultation. GPs diagnosed headaches, 24% of headaches as primary headaches, 6% as secondary headaches, and 70% were not given a diagnostic label, which means they were diagnosed as undifferentiated headache. As you all agree, the GPs cannot diagnose, may not be able to diagnose the cause of the headache at the first consultation. They might need some time. However, out of these undifferentiated headaches, only 5 to 3% of undifferentiated headache received the primary headache diagnosis in the year following. They were followed up for 1 year. And the research team recommended, they suggested that GP's difficulty in diagnosing headache presentation contribute to the high level of morbidity and unmet need in this disease. And research is needed to explore why GPs find it difficult to diagnose and manage headache appropriately. And they recommended developing educational strategies to overcome problem. So this is one of them. Today, this session is educating the GPs how to manage headaches without tears. Yeah, I'm going to share a story that I heard that one of my colleagues, GP, shared with me. This GP, he has this poster in his consultation room. This is a quote from Voltaire, and he has added the title, Beware of the Dog, not the Dogs. And one of his patients found this was very interesting. He took a photograph and posted it on the Facebook. And these are some comments on the Facebook. We as GPs and the patients and relatives, they're worried, especially when they present to a doctor with severe headaches or recurrent headaches. Patients and relatives, they're worried, doctor, is there something serious inside the head? GPs, secondary headache, am I missing a mass lesion or meningitis, serious condition like meningitis. This I downloaded from the internet. Snoop T, not the Snoopy dog, red flags for secondary headaches. Very interesting. This I have given you as a handout for you to take home. You can go through it leisurely. Not only about the red flags, we need to concern about various other aspects when we see patients presenting with headaches. Especially now, when patient is not accompanied by a relative or a friend, how are we going to discuss the future management? Especially a patient presenting to you with following a head trauma with local tenderness, you need to give head injury instructions. You might say if you feel drowsy or if you feel dizzy, you go to the hospital. If patient feels drowsy, how can he go to the hospital? So we need to do something about this. Careful documentation is necessary of the findings of the consultation for future follow-up and also for medical legal reasons. We got to be careful when prescribing. We need to consider contraindications. For example, peptic ulcers and NSAIDs. Patient with asthma and migraine, when you want to use propranolol as prophylactic for migraine. And also interactions with other medications if he is on some other drug. And not to forget, the medication overuse can lead to rebound headaches. Okay, this is the burden caused by the migraine. The second para, measures of health-related quality of life of people with migraines are similar to those for patients with other chronic conditions such as arthritis and diabetes, and worse than for those with asthma. That is why we have invited our content specialist, Dr. Ali Boy, to talk about headaches in general with special emphasis on migraine. Thank you very much, ladies and gentlemen. Dr. Ali Boy, over to you.
Good evening to you all. Firstly, let me thank the College of General Practitioners for asking me to speak to you today. This will be a very basic talk. Since it's a small crowd, I think you can interrupt me if you wish, and we can, make it very informal, so that if there's any doubts in between, you can clarify that, and otherwise we can have some time for discussion at the end of the talk. So what I'm going to talk to you today is about headaches. As it was just mentioned, headache is a very common problem which I think you all plus we see in our daily practice. And you must realize that most of these headaches that we see are benign, but it's always in our back of our minds whether there is a possibility of any serious intracranial problem in the patients that we see. So we might see hundreds of patients and suddenly you find one or two who might have a very serious problem, and we have to be very sharp in trying to pick those one or two patients who might have this problem among all these patients who will have benign headaches. Now, as it was mentioned, headaches, we classify them as primary headaches and secondary headaches. So what are these primary headaches? Now, what we mean by primary headaches is that there is no other underlying cause for these headaches, and the headache is itself the only problem in these patients. So the only problem with these patients will be headache. You can't find the underlying cause for these patients. And some of these primary headaches, the common ones are migraines, tension headaches, cluster headaches. These are the three common headaches that we group under the primary headache disorders. Then you have the secondary headaches, and here headache is one of the symptoms of an underlying condition such as a brain tumor, for example, meningitis and so on. So headache is one, it's like just one symptom of something hidden underneath. And if you look at the list, it is a very long list of conditions starting from stroke, subdural hemorrhages, temporal arteritis, meningitis, benign intracranial hypertension, list goes on and on and on. Trigeminal neuralgias, a lot of facial problems, sinuses, tooth, neck problems, eye problems, hypertension, various drugs that we see use regularly. So although the secondary headaches, there's a long list, they are very often less common. So when we approach a patient with a headache, basically we, like certain conditions, you have to solely, I would say, diagnose it on the history. If you depend on examination to diagnose a headache, if you depend on investigations to diagnose headache, and now there's a tendency of CT scans, there are hospitals who promote now headache protocol to diagnose your headaches, MRI scans to diagnose your headaches. That will never happen. You will be totally misled in trying to diagnose headaches if you depend on MRI scans. Now there is a hospital who has put a poster up saying that there is a MRI scan, the latest MRI scan for diagnosis of all types of headaches. But that is totally misleading the people. Headache is 99% of the time diagnosed on the history, and if you don't take your history properly, you are surely going to be in trouble. So I would say the history is number one. After that, you, as usual, do a general examination and do a specific neurological examination where you feel sorry, where you feel it is certain things where you look for in this examination. So I think I thought I will stress a few things that you should ask in a history. We tend to just ask here and there, not in a particular order. You will have to try to have a systematic history of a headache history, what we call a headache history, where you take a history in a particular order and always try to follow that order so that you can process the different types of headaches as you take the history. There are about 10 points. Some books give 10 points, some books give 12 points. So I put about 11 points that you might have to ask in your history, and which you should probably have a list so that you don't forget in between, because some patients might have just one clue in one of these points which may give the diagnosis, right? And all the others may be vague, right? So unless you pick that particular specific point, you're going to miss it, the type of headache. So first one I would say is the onset. And a lot of people don't stress on this onset of the headache. We have seen these acute headaches missed on several occasions because the history is not taken properly. For example, this acute headache of subarachnoid hemorrhages, we have seen this missed over and over again. It is a deadly condition and you can't just miss it. It's like a crime if you miss a headache of a subarachnoid hemorrhage in a patient who comes to you. It is a very sudden headache, right? You are quite okay at this moment. Maybe you go to the toilet and suddenly you get a thundering headache, which, as if, is the worst headache they described that you could have got, as if somebody hits you from the back of the head. Somebody hits you with a sort of gives a blow from the back of the head. That's the feeling you get. That type of headache you have to differentiate from maybe a migraine headache. It's not on the severity of the headache. Migraine headaches also can be very severe, but it's how it starts. The migraine headaches go slowly, slowly, slowly. At the end of the day, it peaks up. So you have a full day where you slowly, maybe hours sometimes, where it peaks up to a very high level. But subarachnoid, it's in seconds, sometimes in minutes. That's it. You reach the peak very fast. So you should not ever miss a subarachnoid history. We see this repeatedly, and people, it's only on the history sometimes. The patient is after 1 hour or 2 hours, patient is back to normal, and it's ignored, until they get a thundering another subarachnoid hemorrhage. So you have to be very careful. There is nothing else in the history which will give you, the clue. Right? So this is just on the onset. Then the location of the headache also might help you. For example, if it's a one-sided headache, then we always think of migraines, which is often one-sided, not always, but often one-sided. Cluster headaches, I'll just mention a few words later about cluster headaches. That is also typically a unilateral headache. Then the site of the headache, also location, the site, like the temporal region. You cannot miss these headaches of a temporal arteritis. That's also something that should not be missed, especially older person comes with a headache in this temporal region. Number one, you should think of a temporal arteritis because it is also a very serious condition. and if you miss it, your patient can get affecting the eye, and you can get blind also very soon if this is missed. And it's easily treatable condition. So when you have a headache in an older person with in a temporal region, always think of that. Okay, so the attack duration, how long these headaches last, and you must try to get that clearly from these patients. For example, trigeminal neuralgia headache, how long does it last? It lasts seconds. It's like a sudden shock like that, that's the headache, that's the pain that they get. It's a shock. It can keep coming over and over again, so it may last for hours, but each of those is a shock. It's a shock like that. So that's a trigeminal neuralgia headache which lasts seconds. While a migraine should, by definition, can last from 4 hours to 72 hours, right? So we see migraines lasting less than that also if the patient takes treatment early, but by definition, my duration of migraine is 4 to 72 hours. If you have a migraine that is lasting for 5 days, 6 days, then you must think, okay, is this migraine or something else, right? So it should not be a continuous headache. It has then changed over to some other form of headache, or you are missing maybe something else. Now, tension headaches are the ones that last days and days and days. So if the patient has 6 months of headache every day from morning to night, then that is more like a chronic daily headache, a sort of a tension, what we group as tension headaches. So the duration of headaches is also important. Another thing is the frequency of headaches and timing of the day. That's also an important thing that you should ask. Now, frequency of headaches. One condition that is, we often see missed is cluster headache, right? Cluster headache is sometimes, majority of the times, diagnosed as migraines. And there are so many clues in cluster headache which is missed because the history is not taken. Cluster headache diagnosis is mainly on history. So if you don't take that history very clearly in detail, you will treat it as migraine. And problem is that migraines don't, cluster headache treated with migraine treatment doesn't improve, right? So patients go on for months and months trying all kinds of migraine treatment till they finally come up with a diagnosis of cluster headache. So you should not, you should take this history. What is a cluster? Cluster means sort of a group of headaches. You get headache every day for some time, and then you don't have headache for a long time. It just disappears on its own. Whether you treat or not treat, it just goes away. And then it can come again. After 6 months, it comes again, and then you have a cluster, a group, where you have days and days of headache, and then it goes away again. And it's gone for another 6 months. So people have different cycles there. Some people have 6 monthly cycles, some people have 1 yearly cycles. So every year they get this 1 month or 2 months of headache, and then it's gone. So you have to be, you can see that unless you take a history, which is in detail, you can easily miss these headaches. And also this duration of these headaches, as I said, migraine headaches last for 4 hours. These cluster headaches can last less than an hour, right? So if your headaches in patients last for 1 hour, or less than 1 hour, and then just go away before they take any acute treatment, whether they take any analgesic, it just goes away on its own. You must always think of cluster headache possibilities, right? Migraine headaches, usually you get 1 headache a day maximum. You don't get several types of migraine headaches a day. By clusters, you can get 2 attacks, 3 attacks, 4 attacks sometimes on one particular day, which will last less than 1 hour. It's gone. Again in the evening you get one. Again at night you get another one, like that. And so unless you take, ask the detail, the frequency of these headaches and how it is developing over months and years, you will not catch this cluster headache. So one clue of cluster headache is to get this particular part of the history. And also timing of the headaches. You have timing of the headaches, you have to ask clearly, is it morning headaches? As we know, morning headaches, early morning when you get up and you have a headache, then you must think of possibility of raised intracranial pressure, but it is not always so. Most of the time morning headaches are benign. But when you have a headache like that, you must also think of possibility of raised intracranial pressure. Pain severity. Pain severity often doesn't help, to say what type of headache it is. Any of these headaches can be really severe. Even migraine can be severe. Cluster headache is terrible. it's a very bad headache. Trigeminal neuralgia is one of the worst headaches if you are suffering. We have seen patients jump out of the bed and fall on the floor, like with that shock that they get, that sort of headache, the pain that they get with trigeminal neuralgia. So it's very hard to pinpoint and say this is the possible headache, but then that's part of your history which you have to take. The quality of the pain also sometimes is useful, whether it's a sharp shock pain or whether it's a throbbing pain or it's a dull ache, things like that. And your associated features. Now, in migraines, you have associated feature of auras. I'll come to that in a minute. Vomiting in meningitis, photophobia in meningitis, things like that. So, associated features, what, in addition to the headache, what else do you get when you get the headache is also important. Then what makes it worse, aggravating, and what brings it on? So, for example, coughing, sneezing, straining, bending, that's the typical, situations where we bring on headaches of raised intracranial pressure. So, if the person is straining or coughing and they get pressure, we must think of raised intracranial pressure. Migraine can be brought on by stress or menstruation periods, time during the periods. And headaches, new headaches coming at the end of pregnancy or during pregnancy, after delivery, you have to not forget possibility of venous sinus thrombosis. That's one condition which is very linked to pregnancy. That also needs, you must not forget this. Although rare, rare things can happen. So therefore, if you don't think of it, you can miss it. Finally, little other things, what relieves this pain is, for example, migraine patients will say they sleep, it goes away, things like that. Family history, again, certain situations, for example, migraines also, there is a family history where, parents might have migraines. And the impact that the headache is, giving, that just tells you how bad these headaches are. For example, how many days of school the child is missing, how many office cuts you have to make because of this headache. So these are some of the questions that might give you just a full diagnosis. You don't need anything more than that most of the time. If you take a proper migraine or proper headache history, I think much of your diagnosis is there, right? So try to see that you cover all these points when you take a history. It won't take that long, when you start getting used to taking a fast history, I think it won't take that long going through all these points, right? And a little, well, as usual, you have to take other histories. So like the medical history, is there history of loss of weight, is there fever, any other malignancy, we are thinking whether there is a metastatic deposits, a past history of TB, trauma, depression, and various other things. Snoring I have put there because people who snore at night can get morning headaches sometimes due to obstructive sleep apnea. Patients who have sleep apnea problems have morning headaches. And drugs, sometimes we forget the drugs that we give for everyday use, like the oral contraceptive pills are well known to trigger migraine headaches. So you must not forget drugs also. When it comes to the examination, you will see that not much of help in your everyday practice. If you examine, and when we examine, most of the time there is nothing to find in these patients. Majority of the times there is absolutely nothing. That doesn't mean that you don't examine the patient, but you will not be getting your diagnosis most of the time from this examination. So blood pressure you can't miss, because patient, unless he has checked his blood pressure, there is no way he will know there is hypertension. You might look for sinus tenderness. Always check the temporal arteries, especially in older people over 50s, to see whether there is any tenderness there or any thickening of the temporal artery, and whether it has stopped pulsating. And when you come to neurological examination, what I have to say is, looking at the fundi, you cannot, I don't know how many, as GPs look at fundi in patients who come with headaches. I am not sure. I would like to know from you all, just for my interest, as a routine, how many look at fundi, because we have got tricked. There are patients who are very typical migraines, until you look at the fundus, you don't see, the whole diagnosis changes when you look at the fundus, right? There are patients who just come with little sinusitis and you look and to see full-blown papilledema, you know. So, and patients have no other symptom, it just looks very straightforward. Some of them come with very short headaches, you know, you think, you know, you need a 1 month headache for a tumor to develop, but they come with a headache of few days duration, you think must be just a sinus, but until you look at the fundus, you have, you know, sort of, you know, missed. And we have seen a lot of, you know, people who have missed because nobody has looked at the fundi, right? Fundi is difficult to see until you get used to it. You have to practice, right? Most of the time when we also was to, you know, starting with the ophthalmoscope, you can't really see anything, right? But you know, as you practice, you are sure you can at least pick on 1 or 2 things, at least the papilledema, at least optic atrophy. One of the 2 things, it's not that difficult. Once you start seeing it, it doesn't take that long. But I think you have to get used to, as a routine, you should not send away a patient with a headache who comes to you with a headache without looking at the fundi, I would think. Right? It's not correct. Well, if the patient has fever and ill, then you look for neck stiffness, and then you look for other neurological signs like 6th nerve palsy and things like that, which will be like, you know, uncommon to find here. Okay, so quickly to investigations. Again, don't expect to find much in your investigations when you are facing patients with headaches. You do a ESR, especially for people you are thinking of temporal arteritis, where the ESR will be elevated. Skull X-ray, I'll come to that. The imaging nowadays with the CT, MRI, EEG, and then the lumbar puncture. Just a quick word about these investigations. I think most of the people with headaches come with an X-ray of the skull. I think it's utterly useless most of the time. Except if you are thinking of sinusitis, I don't see any use of taking skull X-rays nowadays. You know, it's not going to give you much of information. Hardly any information as skull X-ray. But most of the people, you know, with skull X-rays, I think it's a waste of money and resources, I would think. Looking at enlarged pituitary fossa and all are theoretical. You know, nobody can be, by the time the pituitary fossa is enlarged, you develop so many other symptoms, you know, before you have a patient with acromegaly, you do an X-ray, you find the enlarged pituitary fossa, you know, that is, you know, retrospectively. But to diagnose a person based firstly on enlarged pituitary fossa and all is, you know, like remote. So skull X-rays are not very useful. Okay, then it comes to CT and MRI. Well, nowadays, you know, a lot of pressure by the patients. You know, they come saying, I want a CT scan, I want an MRI scan. That's how they come, you know. And like before you say, you know, you don't need a CT scan, you must have a lot of guts to say, I don't need a CT scan on you, right? And that becomes a little difficult sometimes, you know, because he's asking for one and you're saying no, right? So there is a tendency for people to oblige and, you know, write CT scans. It's a tricky thing sometimes because you'll be doing a lot of unnecessary scans. But then you're also worried that, you know, patient can turn around and go to another doctor who will oblige, and then you might find that there's something on the CT scan. That happens, you know. We have seen patients where you say don't need, and then they will somehow want it, and they go to another consultant and say I want a CT, and he will do it, you know. Technically he will do it but not find anything, but you know, that worry is always there when patients keep asking you, you know, I want a CT scan. That's their presentation, you know, I got a headache, I want a CT. But I think there are good indications for those things, and I think you should stick to that. I'm not going through all those indications, but you must think that a lot of people are having contrast CT scans of not much of use for acute things sometimes. For example, if you are thinking of hemorrhages, contrast is not required, right? Especially if you are thinking of strokes, subdural hemorrhages and things like that, contrast is not required. People do contrast for every patient, but I don't think it's required. You have to select your patients. So, and MRI definitely has its advantages. It is giving less radiation, much safer, and also it can pick up minor things, and especially things on the posterior fossa, brainstem, and things like that, which are easily better picked up from MRI scans than CT scans, right? So that the choice will depend on so many factors, and depends on what you are thinking of as a diagnosis in your patients. EEG is not useful for headaches, right? There are people who do EEGs for everything, right? But definitely headaches you can't, EEGs are not useful. EEG should be basically restricted for drowsy unconscious patients or epileptic patients. So if you're having encephalitis, or I think your abscesses and things like that, you might catch something on the EEG. But apart from for routine EEG on a patient who has headaches is of no use. Okay, so I think the red flags were mentioned. I am just given a list of things where taking a history and examining these patients, what you should suddenly wake up if you hear any of or see any of these situations. Firstly, headache beginning after 50 years. So if you have a person who for the first time starts getting headaches after 50 years, that's a good indication that you have to think of something as a secondary headache, not migraine. You must be careful starting to diagnose the first headache after 50 years in a person to say this looks like migraine, that you have to be careful. So if that's one thing that you have to wake up when you have an older person coming with a new headache. Second thing is the sudden onset of severe headache. As I mentioned before, but you have to definitely take it very seriously. A sudden headache, a very sharp sudden headache, if has not happened before. So it's acute sudden headache. That is also a red flag. And also a headache which changes the character. Now you have headaches, okay, once in a way you get migraines, but suddenly you realize that these headaches have changed, in character. And these headaches become more regular, more different, the character has changed. And when I heard that story where I had headaches for 5 years, and 5 years later the tumor was discovered, I'm sure that tumor didn't take 5 years to grow. And I think the tumor might have been more new tumor. He must have had a migraine which had a recent development of a tumor, unless you have meningioma which might have taken 5 years to present itself. So you can get another headache due to another condition, when you might have starting off with a benign headache, and then you can definitely develop a tumor. Migraine person can develop a tumor. So there are situations where I came to you for 5 years and you couldn't diagnose my tumor. That is, you have to be careful because the tumor might be new and so long you had a migraine, right? So therefore the clue would be that the type of headache has changed, right? So if you have a headache that has changed or accelerated in the pattern, then you also must keep in mind that you might be developing some other condition on top of the original condition. Anything precipitated by coughing, straining, as I mentioned before, that's a clue for possibility of raised intracranial pressure, but although it's given in books, as practical things, we don't see that. You already have diagnosed raised intracranial pressure, and then if you ask back, they will say, okay, it is, when you strain, it is coming. But it's not like where some patients come and tell you that. They never tell you that. So, well, it's probably a retrospect, question that you might want to ask. Night headaches also, and early morning headaches also, again, a feature of raised intracranial pressure. Headaches with fever, again, very often we see patients who come with, and you always see much more where you have 2 days, patients coming in a very short history of 2 days of fever and a headache. Most of them are viral fevers, and but at the back of your mind you always have to think of, is this meningitis or something developing. So it is very difficult when you have a very short history, but then that has to be kept at the back of your mind. Then any focused neurological signs definitely is a very strong indication that something is seriously wrong, right? So if you are developing a sixth nerve palsy or third nerve palsy or facial palsy or something else, you have to think if there's some weakness on one side or numbness on one side, it's very obvious that something, more is happening to this patient. And as I said, papilledema, altered level of consciousness also are clues that something else is happening. So these are some clues that you have to, think more and look for something more serious. Okay, I'll just take a few minutes on one or two conditions I thought maybe worth mentioning, because we would not like to miss these conditions. These are common conditions, and sometimes if you're not careful, we tend to miss these. Temporal arteritis in elderly patients over 50 years, after 50, it's often unilateral in the temporal artery region. So get used to palpating these temporal arteritis and get the feel of that, whether they are tender and thickened and also pulsating. And always check for high ESRs in older patients who come with temporal headaches. Another condition which you should think of is benign intracranial hypertension. Only way of diagnosing this is, to suspect this is, unless you look at the fundi, you will not diagnose this. So it's a younger person who is an obese person, who often a woman, who will come with vague headache sometimes, but until you look at the fundus where there will be papilledema, the clue will not be there, right? So as a routine, sometimes these patients come, they are young, they come with vague headaches, no major clue in the history to say what this is, and you might think it's a sort of a benign headache until somebody looks at the fundi, right? So that's a very good indication that you should look at the fundi in patients, because sometimes you just don't have any clue that something more is happening until you look at the fundus, right? So you can't miss this condition also, because all these are treatable and will not improve on its own. You should not forget drug overuse or drug abuse headaches. Very often, people keep going from doctors to doctors. They all give analgesics. They don't tell that they have already taken some. They abuse it, they take it, they go to the pharmacy and take more. And Panadines and all the NSAIDs they keep taking, and then they start getting these headaches of overuse headaches. Common with migraine patients, they just are not put on prophylactic treatment, they are put on acute treatment. So migraine patients always just wait till a headache comes, they take something for, something for the headache, and they are taking a lot of analgesics, and they end up with this sort of chronic headaches due to drug overuse. Just a quick word about trigeminal neuralgia. You must try to pick these patients up, because very often we see these patients who are late in their diagnosis. A typical patient has this pain in the lower trigeminal, that is mandibular division, a sharp pain, shooting pain coming from the tooth, and often they end up with the dental surgeon. He pulls up one tooth, and then he's okay for a few days. He goes back saying his tooth is paining again, another tooth is out, and very soon by the time they come to us, the whole lower jaw is without teeth. And that is a very common thing that we see. The whole all these teeth are missing by the time they come to us. So it's a shame for them nowadays to pull out teeth, but that's very, I don't know why the dental surgeons don't think of trigeminal neuralgias when people come with pain, which is very typical. Toothache is not like that. Toothache is you experience a toothache, but this is a sharp shooting pain only in that, only traveling like somebody pricking you, jabbing you with something. So it is not that difficult to diagnose. So I don't know why they have to wait till they remove so many teeth before they could diagnose a trigeminal neuralgia. And another feature is the last one, where that this pain is triggered by either speaking, drinking water, also washing face, AC draft coming onto your face. It just comes. If you touch, it comes. So that is very unlike dental pain. Okay, now we come to the topic of migraine. And as you know, migraine is based, diagnosis like the primary headache based on symptoms. So little quick word about migraines. These are episodic headaches. So what one feature is episodes. They are not everyday headaches. They come and go. So in between, so you have a bad headache I said it will last maximum 3 days and it goes away. But it might come a day later. But there is a break. So they are episodes. Right? So these are episodic headaches. They are grouped under episodic headaches and maximum lasting about 3 days. And as I said, you should not be diagnosing migraines in elderly people. The first migraine in elderly people. You can have migraine from young age which is going up to 50 and 60. But for the first time, you should not be careful when you are diagnosing migraines after 40s. And as I said, it lasts from 4 hours to 72 hours. If the patient has a headache lasting 2 weeks, you should not be thinking of migraines. And usually it is unilateral. It's throbbing and pulsating. So that's from your history. And as you know, there is nausea, there is vomiting, photophobia. That is, you can't look at light or the sunlight, the headache gets worse. You see migraine patients, closing the doors, drawing the curtains and switching off lights and hiding, putting a blanket on top of their head and hiding, themselves to avoid the photophobia. Some of them have so much photophobia. Phonophobia means the sound, when there is children crying and playing around you and, the TV on, the headache gets worse. And there is a family history in most of these patients. And one thing you must think, is useful in this migraine is the auras. Not all of them have auras. Auras, 15-20% of the patients might have auras. And auras are usually visual. So you will start seeing as the usually auras come before the headaches. And the duration of the auras about 10-15 minutes, maybe 20 minutes. So you start seeing various things. If you go through the history of migraine patients, as you would know, they might see holes, bright lights, stars, zigzag lines, wavy lines, blurred images, things like that. It will last about 15 minutes and then it goes away on its own, and then usually there's a break between that. So the aura goes away for a few minutes, they are okay, and then the headache develops. So that's the typical way of how it develops, but they can overlap, definitely aura can overlap onto the headache. But usually the aura goes, there's a small break, and then you start getting these headaches and then, vomiting and things like that. So when you have an aura, I think you can more or less be sure that you are heading for a migraine headache. So that's useful to, help you diagnose migraines. But then not all of them will have auras, and some people have aura one day, some people don't have auras. In every headache every headache doesn't have aura. Okay, one last word about cluster headaches, because I thought a lot of cluster headaches are being missed for a long time, and it's a very bad headache where patients suffer a lot. So one clue is the people who suffer cluster headaches are males. Usually migraines commonly are in females, right? So if you have bad headaches in males, which is usually unilateral always, so it sticks to one side. So every cluster in majority of the patients always is either right side or left side. It doesn't keep changing sides. Now migraine headaches, one clue is one day it is here, next day it is on the other side, then it keeps changing sides. But cluster headaches is always on one side. 99% of the time it always sticks to one side. So that's another good clue. If the person says, I get always a right side headache, and it's also the duration of it, it goes away within an hour on its own, and you get more than 1 or 2 attacks a day, then you might think it is cluster, and then you have to take the history where you have a cluster and no headache, cluster and no headache. Okay. And another feature, the last point there, which groups the cluster headaches into a condition called trigeminal autonomic cephalgias, what is called TAC. Nowadays we have a condition called TAC. I thought I'll just introduce this term. I don't know how many are familiar with this, but there are several headaches like paroxysmal hemicrania, cluster, SUNC, various types of headaches which are grouped under the TAC category, which has these features which you will not see in other headaches. And I think it is worth, if you see this type of patient once, you will not forget, because all these cluster headache patients, it's a one-sided headache. If you look at them, you will see they have a red eye. It's a little congested, right? The eye is small like that. It's a little small because they develop a mild Horner's like thing. So they have a little ptosis. It's like that. They have tearing, and sometimes the patients come to you with tears coming down their cheeks. It's so bad when you see them during the headache. And also you have blocked nose on that side. So that is a clue that this is a cluster headache. So you have to, this is one of the types of trigeminal autonomic cephalalgia. So by term itself you can, sort of identify this trigeminal. It's in the trigeminal territory. Autonomic because your autonomic features of, tearing, blocked nose, congestion of eyes, and cephalgia means headache. Okay. So just remember these little things so that you can pick up these patients who come to you with cluster headaches. Okay. I think that's okay. Management, that's the main thing I forgot. Okay, we'll come quickly to management. Can I have a few minutes? It's okay. Yeah. Okay. The triggers of migraine. I thought I just mentioned a few things because there are so many triggers of migraine, and it's impossible to live, and adjust all the triggers because then you can't live in this world when you look at the number of triggers that you have, right? But it might be useful if you can identify the trigger. Not all the people have the same trigger. Everybody has different triggers. So you might be your patient himself may be able to identify these triggers. Right? One is sleep related things like not sleeping enough or even sleeping too much. Now, I myself have migraine, and when over the weekend, if you sleep too much on a Sunday and get up late, you start getting headaches. Right? So sleeping too much also sometimes can get you can get headaches. So you must remember that. Also, disturbed sleep like shift work, right? They can trigger migraine headaches. As I said, stress, anxiety, exams. Traveling long distances, going in the sun, and various types of foods, right? Now, if you look at the list of foods, there's a long list, and if you stay away from all of them, I don't think you will have anything left to eat. But the common things are like cheese, chocolate, and coffee. Those are the three things that we tell, and also a lot of things that have a lot of smell like Ajinomoto and things like that. Those things also can trigger migraine headaches. Also starving or else missing meals or having late lunches, that also can trigger migraines. There's a long list. Anyway, I'll just mention it. Alcohol, especially red wine, caffeine I mentioned, and also menstrual cycles. As you know, especially commonly we see with the monthly periods. Then also change in weather, hot days, warm environment, bad smells, sometimes good smells like perfumes, things can trigger. Bright lights, doing too much exercise, smoking, and also light from computer screens, training on computers, things like that. So you see that so many triggers are there, and sometimes you might be able to avoid some of these triggers so that you might get relief from your migraines. Okay, when it comes to treatment, we treat migraines in divide the treatment into two groups. One is the acute treatment. That means you are treating the headache when it comes. And the prophylactic treatment where you start treatment so that you don't get headaches, right? So you prevent the headaches. There are two different ways of treating them, right? And I think most of what is being done and what we see is that everybody does acute treatment only and stops at that. So patients comes today with a headache, they are given something 3 days, they go away, and then they wait for a few days, they come again with a headache, they take some treatment, they go away, they get tired of you, they go to another person, and he's also treated 3-4 days and they go away. So nobody is thinks of putting them on prophylactic treatment, not nobody, but then there are a lot of patients who are, taking only acute treatment. So we'll tell you when you should switch over from acute to prophylactic treatment in a minute. So the drugs we use can be analgesics like Panadol and paracetamols, aspirin, NSAIDs. All kinds of NSAIDs have been used, right? Commonly we use the ibuprofen and diclofenac potassium. That's commonly used. I think diclofenac seems to be working, quite well in acute stages. ergotamine are now completely out of style now. Very few people are using. We don't use, but still it's in the market, and some people still use it. But there are a lot of side effects with that drug, and it is not anymore recommended unless you are like really desperate to treat some of these patients. And then you have the newer acute treatment drugs, which are the triptans. There are all kinds of triptans. Only triptan that is still available in this country so far is sumatriptan. But there are so many other different preparations. If you look at the BNF, there's tens of dozens of types of triptans, but hardly any difference among them. So all more or less are the same. But you can have tablets, you have injections, because some of them are vomiting so much. You have gastric stasis, sometimes they are not absorbed, so you might have to use another route to give these tablets. So you have subcutaneous injections, nasal sprays and things like that for these triptans. And often you have to give an antiemetic along with that because of gastric stasis and vomiting associated with migraines. So that's when the patient comes with an acute headache, you give an analgesic with an antiemetic. That's acute treatment. So now how do you decide which patient you are going to put on prophylaxis, right? So that is very important to know. Generally, we use the rule, if you have more than 3 to 4 headaches a month, we feel that you should be started on prophylaxis, right? Different people have different opinions, but I think the general consensus is 3 to 4 headaches a month, right? So maybe average 1 headache a week. If you have more than that, you should be started on prophylactic treatment. But sometimes even less than that, you might have to put them on prophylactic treatment. If your headaches are lasting very long, like 12 hours, 24 hours, and it's a very bad headache where the patient says, I can't bear this headache, even if it's once a month, I just don't want this headache. That sort of bad headaches, sometimes even if it's once a month, you might have to put them on prophylaxis. But on average, general migraines, about 3 to 4 headaches a month, they should be started on prophylactic treatment. And sometimes, there are people who are allergic to all kinds of analgesics. They don't tolerate any of these acute treatment drugs. So when they get a headache, they can't be given anything. They are allergic to paracetamol, allergic to NSAIDs, and not much you can give them. So those patients also, it's good to prevent these headaches by putting them on prophylactic treatment. And when you start prophylaxis, often we treat minimum for 3 months, but sometimes you go up to 6 months at least before you take it off and see whether these patients are getting the headache again. And finally, what do you use to treat the prophylaxis? Nowadays, more and more drugs are coming into the market to treat prophylaxis. The 4-5 groups are these: beta blockers. This is the oldest group where we commonly use propranolol. Now, how do you select? Before that, I'll just tell you the drugs. Then you have the calcium channel blockers. Among that, flunarizine. The antidepressants like amitriptyline, the pizotifen group, and the antiepileptics like valproate and topiramate. So these are the commonest drugs that we use to prevent headaches. Now, when you have a situation with so many drugs, you will think when a patient comes to you, which one would you select? How do you select which one to give whom? And that's sometimes difficult. But you will see that most of these drugs are used for various other conditions. They are primarily, some are epileptic drugs, some are hypertensive drugs, some are depression drugs. So if the patient has a little depression with migraine, good, then you can use amitriptyline. So that's one way how we select. If the patient is a hypertensive, then we might use maybe propranolol or metoprolol or verapamil or something so you kill 2 birds with one stone, sort of thing. So you treat 2 illnesses with the same, one drug, rather than giving them different drugs for different things. So one way of selecting the drug is other comorbid illnesses, right? So whether if the person is epileptic and having migraine, good, then you give valproate, it's sorted, right? Rather than giving propranolol and valproate, 2 things. That's one Second thing is based on side effects. Now, if you look at these drugs, each one has its own side effects, right? Now, like propranolol, as mentioned, asthmatics, you have a problem. But propranolol is generally good, although list of side effects is a lot. Impotence is another problem we face. But apart from that, bradycardia, impotence, and things like that, it is usually very useful because you don't need very, very big doses also to use. Nowadays, we are using metoprolol also because the side effect profile is better with metoprolol. Now, one problem we have is with these drugs is one drowsiness, right? A common problem with all of these drugs is the drowsiness. When you give school children, commonly and office workers, they fall asleep at work, in school. So all of these drugs, most of these like flunarizine, amitriptyline, pizotifen, and antiepileptics, all of them have a lot of drowsy effect. So best when you're facing a younger person, probably then propranolol, topiramate are good drugs, right? So a younger person who you are feeling that drowsiness is not a problem, then you can use that. Other problem we face is weight gain, right? Weight gain is very common with all of these, flunarizine, valproate, pizotifen. They put on weight, a lot of weight, and since women are the people who often get migraines, it's a problem, right? So only drug here which anybody knows which can, make you lose weight. Very popular drug nowadays, where everybody wants it, and after the migraine is better, also they want to stay on it because they are losing weight. It's topiramate, right? So topiramate is very useful because of obese person comes with migraine. You don't want to give valproate; they will put on more weight, right? So topiramate is, so that's how we just think of what to give, right, on various side effects and other comorbid situations, right? But you must think of also side effects of these drugs. You must remember, like topiramate is although now very frequently used, it has problems of glaucoma. So you have to be sharp and not miss those things, right? Because there are some bad side effects sometimes, right? Also pregnancy, because younger people get migraines, they suddenly on taking valproate and they come saying I'm pregnant now 2 months, then you are in trouble, because you expose them to a very bad sort of drug in pregnancy. So a lot of things you have to think before you select a drug, right? So I think that's all I would think I have to say. If there are questions, I'll be glad to answer. Thank you.
Migraine, most of the patients come when they are relaxing.
When they are?
When they are relaxing.
Relaxing.
In the sense, the patients go to work in the morning, and in the evening they come, and they start getting the headaches when the feet are up. Any idea that why do these people get a migraine?
It's difficult to say in that situation. I think it is a headache that is building up during the day. Maybe the work, returning home in the sun, long distance travel, all that. And since migraine doesn't develop suddenly, it's a very gradual process, right? So you start getting a very low grade headache, and you don't, while you're working, you might not be realizing that you have that much of headache. When you go home and start relaxing, then it builds up. And probably that, I think that is one reason.
But it is a known fact that the migraines start in the evening. It's a known fact.
It is,
and
yes.
As a GP,
Yes,
I
you
have
see,
got most of the patients in the evening.
I don't know why it should be. That's my explanation. They don't talk about migraines as such in the it's not in the definition of migraine. Evening part doesn't come in at all. Like you might see it true, but I don't know why. But it is not there is nowhere it is mentioned that you should think of migraine if it comes in the evening. It's not partly anywhere in the diagnosis as far as I can think of. So just because a headache came in the evening to say it is possibly migraine, I'm not sure. No, yeah, I know what I'm saying.
Migraine and tension headache
Sorry, you can?
Migraine and tension headache, they can coexist. And the tension can precipitate migraine, especially tension at work.
Yes.
Yeah.
Yes. That's what
I
I'm
would-
saying, yes.
Yeah, and they coexist. And some people, they have features of migraine plus tension.
Yes, these are
For
common
example,
headaches. So as
yeah.
I said, they can have more than one type of headache at the same time,
Yeah. And they have scalp tenderness with nausea and things. So I think it's a mixture of tension, headaches, and migraine.
When you are giving prophylaxis, propranolol or something, do you give a bigger dose or a smaller dose?
I tend to give a smaller dose because most of the people, why should you give a bigger dose if the small dose is working? You can try on like what I give is 40 BD like, and some people give very small doses of 20 a day, but books don't say that to give very small dose. It doesn't seem to
Some
work.
people give 80 twice a day
Yeah.
or 3 times a day.
No, but then you are also having problems with that dose. You have to be careful. 80 times a day will drop your blood pressure. It can cause bradycardia and various other side effects. So, whether you need so much, I know we are not found that you need so much of propranolol. Most of the time, I think 40 BD is often enough. I don't think you're asking for more side effects, more monitoring and things like that. So, you can step up the dose if that is not working, probably. But you can go, if you look at the dosage in migraine, it goes up to 240 milligrams a day. Like, they say you can go up in dose, but I don't know whether, if it's not working at 80 milligrams a day or 120 a day, whether 240 is going to make a big difference. It might be when you have so much of choice, you can change the drug to something else.
I just would like to know whether what I am practicing is correct. When I start on propranolol, one thing I look for is whether the headache is coming down. Other thing is the pulse. And then I start titrating the dose. And I have seen in my experience some people needing 80 milligrams 3 times daily, 40 milligrams twice daily. Right? It depends on
Yes,
different things.
see, that's why I said, it depends how much you want to push that drug. Like if you are persisting on only propranolol, then you can go up to 80 TDS. But, because we have such a big choice, we sometimes, switch over to something else. So, I as a habit don't go up to 80 TDS. That's my practice, but, you definitely can use 80 TDS, there's no problem at that. If a smaller dose doesn't work, I just change you to something else.
And how do you continue? I normally start slowly tailing off the drug little by little. Is that a correct practice? Or is
Tailing off.
I think if I start 80 milligram 3 times daily,
Yeah.
after about a month or two, I make it 40 milligram 3 times, 40 milligram twice, 20
Yeah,
milligram twice, and stop it.
generally they say you should treat at least 3 months,
Yes.
right? So you should be like well controlled for 3 months, basically. I
The
would
same
think so.
dose. Is that what you mean?
Yes, probably you can start tailing off after that, but it's so variable, it's so variable. So thing is, when you start cutting down the dose, you might get the headache again. So you'll have to then again step up and continue it longer. That's all. So thing is, if you're on a smaller dose, then you can without fear continue it. If you're going on 80 days, you need closer monitoring. And if you're going beyond that also, you will need to check, especially older people, you have to be careful. Sometimes we see patients coming with brady, they come and fall in the emergencies, they are falling down because they have bradycardia. So you have to be a little careful. So best thing is not to take risks by giving very big doses, You can add a small dose of flunarizine onto a propranolol of 40 BD, simple as that. You are dealing with lower side effects. Although you are giving 2 drugs, sometimes you use 2 drugs at a smaller dose so that the final side effect profile is much less.
But it may not be effective.
It is effective at a smaller dose. It's effective.
And when you are giving amitriptyline, I mean, that also you
See,
use a small
amitriptyline
dose,
also,
is it?
yes.
10 or 25.
See, amitriptyline, if you see a depression patient, he can take even 150 milligrams without falling asleep. You and I will take 10 milligrams, you'll be knocked out tomorrow whole day. Right? And I'm sure people come back saying, I'm not taking this drug. If you look at all those who are prescribed amitriptyline, our patients themselves are slowly, deleted that drug. They have identified the drug and not taking that drug because it's an impossible drug to take in a person who is like, otherwise okay for migraine alone. They can't tolerate mimetically. It's so drowsy.
But you are not using the antidepressant dosage.
Yes. No, that's the thing. We are using a very small dose. Even that small dosage is also difficult in some people.
I usually give half a tablet.
Yes. Yes.
12.5.
Yes.
Then after about 3 or 4 days, we increase that.
Yes.
That is the normal.
Yes, that's correct.
But it is not the antidepressant.
No, definitely not. Yes. No, what I'm trying to say is that depressed patients taking the big dose, they are not drowsy. They tolerate it very well. But a normal person taking a very small dose sometimes don't tolerate that. So probably the comorbid features, some way it's masking the drowsiness.
I would like to thank both the speakers on this headache topic, which was well tackled. But I would like to just, on the last point which we just raised, I got a patient recently who was seen by a neurologist, and he has given very high doses of propranolol, 80 milligrams TGS and so on. And the patient, while crossing the zebra crossing, just collapsed. And luckily, the traffic, the vehicles did not run over. As I completely agree with you that small doses are the best in most patients, and you can, if small doses don't work, you can have a mixture of another drug. The question I wanted to ask you was, you have given a whole list of drugs which cause migraine and which you should avoid, and in that you had put chocolates. But the US Migraine Society recently has advocated chocolates, and especially the brown chocolates. Is Janto
Dark chocolates.
Yeah, dark chocolates. Are you aware of that?
No, I'm not aware, sorry, but it's tricky because caffeine itself, is used to treat the migraines, and caffeine is also listed as causing migraines also. So the caffeine in the coffee and things like that were listed as the cause of migraine. So I think there is some dual thing here, where in some people it might help, some people it might make it worse, I think. But I'm not sure whether they ask you to eat dark chocolate to help the migraine. I was not aware, sorry. Is it? That's what they say? Or they allow you to eat dark chocolate?
How do you treat cluster headaches?
Yes, the drugs that we use for cluster headaches is very different. The drugs that we use for cluster is prophylaxis. One is verapamil, lithium carbonate. Those are the two main drugs that we use. So you see that they are not the normal migraine drugs, and they respond extremely fast to those two drugs, verapamil and lithium carbonate. So that is why patients who are on having cluster and propranolol and amitriptyline and flunarizine, and they just don't respond.
Do you use oxygen under pressure?
No. No, we have not had the situation of using that. Probably because by the time patients come, the headache's gone. It lasts only short time, so it's lasting. As I said,
It recurs.
I know it recurs, but by the time the patient comes for the next headache to a place where you can find the oxygen and give it like that, I don't think I have not seen anybody like using that sort of thing. It is one of the one of the treatment for acute headaches, but using wise practically I don't know. Probably if it was like migraine lasting for days, then we would have used it much more frequently. But some of these headaches go away in half an hour. So by the time patients try something at home, and however much you say they try something at home, by the time they come to you, it's gone. So you never see. I've seen only one cluster headache during the headache. Like all of them come saying I had a headache yesterday or something like that.
Migraine is associated with stress. When stress is relieved, also does the migraine come, like weekends? I mean, I have seen a few people who say Monday to Friday nothing, Saturday, Sunday when I'm at home, it's a mess.
Well, The better half must be responsible. I think.
Yeah, exactly. They say that I like to go to work.
Yes,
Because if I
because
stay at home, headache comes.
yes, better half is at home. Like maybe that sleeping too much. As I said, sometimes
right,
you sleep
okay.
too much.
Oh, right.
That also is a factor which is. So there are so many factors. It's very hard to pinpoint. Most of the patients can't pinpoint what is causing what. But it may be one of those various reasons.
In temporal arteritis, how long you have to give steroids, prednisolone or whatever?
Yeah, it's a long. Well, there's no. Yeah. The duration will be like about at least about a year, at least. Right? At a small dose, you start with a big dose, and then once you have got that under control, you have a maintain. Like most of these arthritis and things like that, most of the things you start with big dose. Once you've got the correct control, you bring it down to a very small maintenance dose, and you maintain that. As long as there is no headache and ESR has come down, you're fine.
I was told that at least minimum 5 years should continue the steroids.
Yeah, it's as I said, minimum of 1 year, but anything beyond it, it's variable. I think we tend to we are always worried of steroids for a long term, and when we come to about 1 year, see when we are on a small dose, if the ESR is remaining low, you can take it off for a while and see what happens and follow the patient. If it comes back, you can put it back.
Do you do a biopsy in diagnosing?
Well, that is one of the criteria of diagnosing temporal arthritis. But there is a problem with the patient's reluctance to go for a biopsy. That's number one. Because most of the patients, say we don't want a biopsy. Like fair number will say we don't want a biopsy. And then we are a tricky situation where you have to, on suspicion treat. And very often those ESRs are not that high also. They are like 40, 60, and you're not sure sometimes what they are treating. But then you can't miss it also. You can't wait till the ESR goes to get a tender temporal artery, to get a non-pulsating temporal artery, and all that is like theoretically there. But very often when the patients come, you don't find all those things. You just have to assume that you don't want to miss it also. So you might have to empirically treat these patients if they are not coming for biopsies. Thing is, when biopsies are done also, you have to take the appropriate length of the temporal artery. Very often people do very small biopsies and you get a negative biopsy. In fact, it is missed, and then you get a false assurance that this is not temporal arthritis, and then you might miss it also. So you have to be careful when you're dealing with that. So that's again one reason sometimes when you're empirically treating, you are reluctant to, you're not sure, are you treating that condition or not? Sometimes when you go 3 months and the headache has gone, you're not sure now, was that temporal arthritis, in fact temporal arthritis or not? And then you want to maybe take it off a little because you're giving a bad drug, prednisolone. You want to take it off and see what happens. And keep off. That's one of the reasons, if you are 100% sure, then you can go up to 5 years. But very often, you are in a situation where you are not sure. You are just, sometimes we treat, assuming it is that.
Thank you very much, Dr. Aliboy, for that informative presentation. And now there's a message from the sponsors.